service reform. Just want to thank our 4 brilliant partners who make these events possible. They are SIPFA, the WEA, Reed in Partnership, and the Institute of Employability Professionals. Very grateful for all of their support tonight and at each of our monthly events. Really delighted we've got a packed room, almost standing room only, and we're going to be discussing a very interesting topic, which I'll tell you a little bit more about very shortly. Just very quickly, we'll finish at 6:15 p.m, so we've got an hour and a quarter. We're going to have some opening remarks from the speakers, and we've got quite a lot of time for Q&A, so get your thinking caps on. You can stay around for a drink afterwards if you would like. So what we're talking about tonight, as we gear up for the general election, which feels like we've been gearing up forever, but I think we can say that. Public service reform, I think we'd all agree, is firmly back on the agenda, and that includes a increasing focus on prevention, which we will hear plenty of about tonight. There's growing momentum, I think, around the agenda, around the idea that public services need to finally deliver that much heralded pivot to prevention. And I think there are increasingly some ideas about how we might do that, which I'm sure we'll come on to talk about tonight. In January, Demos called for a more preventative healthcare model, drawing on some research that we did in partnership with Breast Cancer Now, which I'm sure we'll hear more from Delith about. And last year in September, Demos set out some proposals for a new government spending framework, which would include a stream of government spending focused on prevention, sitting alongside revenue and capital. And for the nerds, we called it PDEL, to sit alongside RDEL and CDEL. And I'm delighted that we're working with Anita Charlesworth again this year at the Health Foundation to develop those ideas. There's a lot of talk here, and I think we need to talk about the politics of this as well, given it is an election year. How can we take this push for prevention, which I feel is growing and is a growing movement? How can we take it to the next level? How can we overcome the political barriers that might remain? And how can we ensure after the next general election, whoever wins, there's a real push for prevention? So I'm delighted to welcome 3 brilliant guest speakers to discuss these matters with me. To my left is Baroness Delith Morgan. Delith is the Chief Executive of Breast Cancer Now, and as I said, we were delighted to work with you earlier this year on research around how to ensure a more preventative healthcare model and calculating some of the economic costs of breast cancer. To her left is Lord James Bethell. James is I think a brilliant champion for public health. And is recovering from well, I don't know if you're recovering, maybe post-recovery from the London Marathon. So well done.
Putting a brave face on.
Thank you for hobbling here tonight. He was recently Minister for Innovation at the Department of Health and Social Care, and has been really instrumental in a lot of the policy work that's growing around public health and prevention at the moment. To James's left is Anita. Anita Charlesworth is the Chief Economist at the Health Foundation, previously Director of Public Spending at Her Majesty's Treasury from 1997 to 2008. As I said earlier, we're delighted to co-author the paper calling for a preventative spending category last year, and we're going to be working more this year on that. So 3 great speakers, a packed room. I'm really looking forward to this. So we're going to have some opening remarks from our 3 speakers. I'll abuse my privilege as chair and ask a couple of questions, then we'll open it up. So how do we deliver a prevention revolution in election year? Delith, over to you.
Wow, that's no mean introduction. Thanks very much, Ben. And I'm going to kind of feel a bit like, and if anyone can remember Val Dunican, I'm kind of half on and half off, half off my stool here. So yeah, it's a real pleasure to be invited to take part in this discussion this evening. For me, it's the most important discussion that we need to have with regard to the forthcoming election and the future generally. And I'm really delighted to be on this panel with such important contributors. I think from Breast Cancer Now's point of view, we were delighted to work with Demos recently to work with a really esteemed think tank looking at the issues that we're concerned about from a very independent perspective, because we're aware that we are totally focused on the issues around breast cancer that affect women with breast cancer and everyone who experienced the impact of the disease. So we're kind of, one of the biggest things that we worry about is that because breast cancer is seen as, for some people, as incredibly survivable if it's diagnosed at stage 1. You can be looking at survival rates of up to almost 100% for 5 years. But the impact of breast cancer is felt much deeper than that. So we wanted to look at the overall impact of breast cancer, and then some of the specific interventions that could impact on the cost of breast cancer, interventions that we would see as preventative. And we think about the preventative nature of these interventions as potentially in a broader sense than perhaps Demos do, and possibly the Health Foundation, because what we're talking about here is not necessarily prevention of the disease of breast cancer occurring in the first place. We're talking about prevention of early death and the impact of breast cancer on people's quality of life and length of life. So I don't know whether you'd want to get into a debate about how you define prevention. The important thing is that you'd probably classify what we're talking about as secondary prevention, but it's still about stopping people dying of breast cancer. And the work that we were delighted to do at Demos is really important because it shows that some of these interventions that we looked at could not only improve the outcomes for people affected by breast cancer, but they can also really significantly reduce the costs of both the economy, to the economy, but also to people's well-being. And that we would hope would be an incentive to politicians to champion the kind of interventions that we're talking about. But just some context on breast cancer before I go further. We have seen survival rates for breast cancer improve really significantly over the last 40 years. And that's really very much about earlier diagnosis and improvements in treatment. People are well aware of things like the introduction of hormone treatments, targeted treatments, better diagnosis. And this really is cause for celebration. But what we worry about is it means that people think it's a bit of a done deal. So let's think about other conditions. But breast cancer is now the most common cancer in the world. It's starting to create real impacts in low and middle income countries as well as developed countries. And we know that in the UK, for example, 55,000 people are diagnosed with breast cancer every year. The screening programme, which has been heralded as one of the best in the world, is now struggling in some parts of the country, really struggling. More people are waiting longer to be diagnosed and start the treatment that they would reasonably expect. And not everyone is getting the care that they need to support their emotional well-being, which we see as being key. And then, of course, 11,500 people will die of breast cancer, and that's the secondary incurable breast cancer every year. So and that number hasn't changed anything like enough. So the work that we did with Demos was really to shine a spotlight on the burden that breast cancer creates on people who are living with the disease and on the economy. And it showed that the cost of breast cancer to the economy is as much as 2.6 to 2.8 billion pounds in 2024. And that was a very conservative estimate. And the costs covered things including the NHS, cost to the NHS of diagnosis, of treating people, the cost to society of the loss of productivity, to patients and their informal carers, and also the individual costs that people bear, like out-of-pocket expenses, the loss of income from work and so on. And we know that those are significant for individuals. And if nothing is done to prevent the further development of breast cancer going forward, we would see that those costs would increase by 40% over the next 10 years, so by around about 3.6 billion. So we're looking at the costs of this so-called done deal increasing really significantly. So this is dwarfed also by what I consider to be really important aspects of this, by the well-being costs. And it was really interesting because the costs to employers were not great. And that's because, of course, we know that, the women's impact on in work is obviously less than men, but the well-being costs of breast cancer, those costs incurred through quality of life, early death, the impact on carers, the impact on parents and children, that was estimated at a staggering £17.5 billion in 2024. So those are large numbers. So there's hope, though. So while we kind of, bundle up these huge numbers, what we're really interested in is, what can you do? And how can you reduce those costs? So we modelled 3 interventions that would reduce the impact of breast cancer on those affected, and the costs on the economy. And the first one that we looked at was screening uptake. And I said earlier on that the screening programme is really struggling. It's it's failing to turn the tide on. It's diminishing take up. So we looked at that, the cost of improved screening uptake, the cost of employing more clinical nurses, and then the impact of more people returning to work following their diagnosis. And on the screening point, which I thought, given the conversations that we're having today, screening, as an example, breast screening can detect cancer at the earliest possible stages before a woman can feel it herself, when the treatment is most likely to be effective and successful. But we know that invitation acceptance, that's been in decline for more than a decade now, and at the moment it reached recently 60%. It's now gone up to a very tiny amount, and that's 10% below what's recognised as the kind of effectiveness 70% take up level that makes the screening service cost effective. So uptake amongst those receiving their first invitation, which is a really important moment, is as low as 50% of women accepting their first invitation. And that's important because we know that if you accept your first invitation, then you're much more likely to carry on and accept your second invitation and go on throughout your life. So real concern about the state of the screening service and uptake. And the modelling that Demos undertook for us was around increasing uptake from 2019 levels to what's known as the achievable standard of 80%, which would diagnose more cases of breast cancer at an early stage and produce savings to the UK economy of around about 96 to 111 million pounds in 2023, which is almost the cost of the whole service, actually. And it would lead to savings of well-being. So that's, what most people want to see in their lives, of around about 1.2 billion in the same year. So that's why we are now running a campaign, and have been for quite some time, called No Time to Waste. And we are calling on the government to get on with running a national awareness campaign. It's hard to believe that there isn't one, to encourage people to take up their breast screening invitations. And we're calling on NHS England to do that. And of course, if they start doing it, then there will be benefits across the UK as well. So we hope that our work with Demos will act as a bit of a catalyst to change the conversation around breast cancer, and to say that yes, there are interventions that can be made that will have a positive cost benefit for the NHS and for society. And it's not rocket science. It's very, very well understood what works. People. I think we had a response from NHS England saying, "Oh, we'll do a pilot in London to see what works." No, we know what works. People know what works. We just need to get on with it. So that's where we are at Breast Cancer Now, and why we're so pleased to be part of bringing some kind of practical kind of experience in a particular area to the very important wide debate around prevention and how we really need to get on with it. So,
thank you, Dara. Thank you very much. to you, James.
Well, that was just the most spectacular and convincing case study of why prevention works and why we should be focused on it. I'm going to talk about what you call the wide and important debate, if that's okay. I'm going to try and whistle through a few slides just to sort of keep things entertaining. So I think the most important thing to realise is that this is an important debate to have, because our health system at the moment is not doing well for us as a nation. We were once, quite a healthy nation, and we have slipped down the rankings in a very, very big way. And we need to acknowledge that. We don't. I feel very frustrated from our own politicians that this is not considered to be an emergency, some kind of significant crisis. We know our trains are not working. There are some things that we acknowledge don't work. Potholes. But why can't we just be honest with ourselves that something's broke on our health? And we don't have to finger point to it, but just some honesty, I think, would be very helpful. Certainly, that's where the public are. The public are deeply concerned and in a very immediate way about the health of their children, their parents, and themselves. And not only is it generally very poor, it's deeply unequal. I happen to choose this graph to show it, but you can, just get Michael Marmot going. He will give you 25 million different graphs to explain how unequal the health outcomes are in this country. They are unequal in a lot of countries. They are particularly unequal in the UK. So the really big problem here is, women are only the life expectancy for women is enormously different between the deciles here. You can find even more graphic differences between Berkshire and Blackpool if you really hunt them down. But for me, this idea that you have 52 years of healthy life and then 26 years of unhealthy life at the end of it, this is a matter of massive national significance. It means that we've got a huge cohort of people who are unproductive for a big proportion of their life, a third of their life. And that's no way to run a country on a personal basis. As you said, in terms of well-being, that's a disaster. And economically, it's a big. So it has suddenly become a big issue, I think, for the higher-ups, for the mandarins, for the people who make the real decisions, because of the huge dropout from the workforce. It's 2.8 million now. This graph's slightly out of date. It's about 680,000 people have dropped out of the workforce since before the pandemic. The OBR figures in July of last year on the fiscal sustainability report estimated that was about 20 billion. Probably now with the extra numbers, more like 25, 30. And the two things to know about these people is there's very, very little chance of them returning to the workforce. I mean, like minimal chance. So that is a lost cohort. I mean, we can replace them with immigration if you like, but that's quite an expensive way to run a workforce. And secondly, there's probably another 500,000 ready to go. And in fact, when they said that 8 months ago, that's exactly where the line is going. So this is like the education budget just gone. We can't afford a navy or even a defence budget if this is how our workforce productivity is going to. And the projections for UK morbidities are really daunting. So the people who are dropping out of the workforce have an average of 3 and a bit morbidity. So they have something like a bit of cardiovascular, a bit of respiratory, and a bit of mental health. Of course, that's an average. So there are some who have got 5 or 6. And if you look at the growth figures, these are the projections from Anita. Very, very good and absolutely terrifying report. If you want to scare your children, chuck that at them. It is ramping up. And I think that I'm not a clinician, but the picture you get is not that this is one disease. It isn't just breast cancer or just heart disease. These are the manifestations of an underlying poor health. And it is that there are just too many people who are carrying a bit too much weight, who are smoking a bit too much, who are drinking a bit too much, who have hypertension, maybe because they hate their work, and their unhealthiness expresses itself in a series of diseases, including cancer, including heart disease, including respiratory disease, including musculoskeletal, which is and including diabetes, which we now have 6 million. So it's a kind of like it's a triple shocker. We've got huge demand for resources. We've got like our burden of disease is huge. Within the NHS, the treatment system has not made productivity gains, to put it politely. And the NHS budget, I mean, the NHS is only one part of the health system, but it's a very important part. The budget's gone up from 100 billion to 180 billion with a reverse impact on the underlying health of the country. So the Treasury, not unreasonably, are thinking, what on earth's the return on investment of this stuff? We're spending a fortune on doctors and nurses and hospitals and medicine. And the country's getting more and more unwell, and people are dropping out. So there's a real crisis. I mean, the model is broke. It is just fundamentally broke. So recognition number one, our health is not good. Number two is the model is significantly broke. You can see where I'm going with this. So obviously we have to move upstream. We have to shift. And everyone knows this. It's written into the Hippocratic Oath. It's written into the NHS plan. All the policy is written. Richard Sloggett, sitting at the back there, wrote quite a lot of it. It's all in white papers and green papers and plans and what have you. But we really do need to make the commitment to enact it. And I'm going to make now a series of political points, so not policy point political. What is happening here? I think that there is underlying shifts in the politics around health that are not recognized in the bubble, but are very, very powerful. And I'm very encouraged, frankly, by what I see, partly because trouble is good for change. So take Wakefield. You know, the story of the DPH's battle against KFC in Wakefield is a real metaphor for the frustration that communities feel about being able to determine the healthy environment in which people live. KFC are building 500 more outlets. Quite a lot of them are in the kind of brownfield sites that are next to schools. That picture, can you see the picture? Red is outlets, blue is schools. I mean, it's just a total shocker. Obviously, putting KFCs near schools, right? You'd have to be a genius to work that one out. And when the DPH sought to roll over the existing rule that fast food outlets wouldn't get planning permission within 200 meters of a primary or secondary school, that she was overruled by the planning inspector who took the view that the epidemiology of the causal link between junk food and obesity wasn't persuasive, and therefore he overruled her. Wow. Now, this is a planning inspector. What an idiot. How dare he make a decision like that? How dare KFC go to a JR with QCs and argue that kind of stuff? It is totally outrageous, and to me speaks of a massive crisis in the sort of democratic process around health. And I say this because I can see a real rebellion on our hands. Secondly, there are some things that are clearly working. You know, the idea that there are no levers and we don't know what to do and it's all very difficult and we should, pilot something. Forget it. I genuinely believe that the levers are there. As Dallas said, some of this stuff is really not rocket science. We could massively reduce breast cancer, for instance, if we just did our screening programs properly. If Siddle has taken whatever it is, 56 million tons of sugar out of the system in a relatively short amount of time, whilst, by the way, increasing the total market for fizzy drinks, which is good news for business, good news for jobs, good news for the economy. I mean, that points to there being something to these kinds of interventions that can make a big difference. And of course, there's queued up a number of other ideas, all of which, they've got problems, you can say, but something like ULEZ. I live in Notting Hill. I've born and brought up in the shadow of the M40. I love ULEZ. I mean, I think it's brilliant. I now have a much healthier life. My 4 children will probably have a slightly higher IQ than they would have done otherwise because of the lack of smog and smoke in our house. And I was in the hall when Rishi announced the smoke-free generation bill to the Conservatives, and they all clapped like mad. My goodness, who would have thought that would have ever happened? So I genuinely think a lot of this is shifting, and people in this room probably know the numbers in terms of polling. By the way, there is similar kind of numbers for almost every one of these interventions. If you look at the gambling profits levy, if you look at ULEZ, if you look at sugar taxes, very, very strong. And the big kind of like penny drop moment, I think, for policymakers was the lockdowns. We were told at the beginning of the pandemic, Minister, you're only going to get 3 weeks. It's a single shot. There's going to be civil disobedience and all kinds of resistance if you try and lock down the country for more than 3 weeks. You've got to be really cautious. Don't lock down too early. That was the conventional wisdom, as you would have heard in the inquiry. Boy, oh boy, that was wrong. The British public embraced lockdown. Why? Because they were worried about dying. They were worried that their children might die and their parents might die and they might die. And they could see that we needed to protect the NHS, and they understood the logic that if millions and millions of people were all sick at the same time, the system wouldn't be able to cope, and it would be like Spain in the bad moments. So the idea that the public are frightened of the nanny state, or are in somehow worried about the donut being taken from their plate, simply isn't right. And Liz Truss is living in fantasy land. And then lastly, another big driver, I think, of change on the prevention agenda is that a lot of the really exciting technologies around genomics, big data, algorithms, diagnostics, polygenic risk scoring are in the preventive space. There are great advances in treatment as well, but a lot are in screening, diagnostics, and all the things that Dilith was referring to. And I think that's a real drive of change, because if we were having this conversation 30 years ago, we'd really be talking about population-wide measures. We're going to ban everything for everyone. Now there's a much greater emphasis on personalized public health, interventions that can be targeted at an individual based on their own characteristics. Now, at the moment, the prevention programs are drastically underperforming. And therefore, we have this problem that prevention doesn't seem to be working because we're not doing it. Right? It's like pretty simple. It ain't working because we ain't doing it. And it is absolutely shocking to me that we are behind in this kind of way. I mean, this is Ant and Bee stuff. This is like not mending the roof. It's and breast cancer screening being a good, but not the only example of that. But I see the public actually really changing their mind on this. The smartphone-free childhood thing is a mental health rebellion. It is parents saying, what you're doing to screw with the brains of our children is unacceptable, and we are angry and emphatic, and we want a really big change. I don't know if they're going to succeed in banning all under 16-year-olds from phones. That's quite a tall order. But I can tell you the anger and the frustration is definitely there. And campaigns on things like screening are becoming more and more common. And as I referred to, on things of support for restrictions on obesity are very, very strong indeed. So where does that leave us in terms of the macro politics of it? So the old recipe, but from all the parties, was more hospitals, more nurses, more doctors. In other words, more infrastructure, more kit, more time in front of a clinician, and more care, sort of a workforce commitment. And that retail political sort of arms race between the two parties has run for about 20 years and is totally out of puff. I mean, it definitely helped the Conservatives win the 2019 election, and there was a heartfelt commitment to those numbers, and some of them have been hit, for instance, nurses. Some of them have been missed by a mile, like the hospitals. But what is collectively clear is that that is not winning the health battle, and there's no more doctors to hire anywhere in the world. Quite a lot of our own doctors are quitting anyway. So that's a sort of unsustainable arms race to be in. So the conventional warfare, charging around in sort of armor with a lance and a steed, that ain't going to work in the sort of modern world. Very interesting that Rishi did his smoke-free generation thing. What extraordinary, because he's such a sort of raw-blooded capitalist, and yet he did feel instinctively, he has children, he's a very good dad, what have you, that this was the right thing to do. Doesn't actually take a cigarette out of anyone's hand, which is quite useful politically. But in terms of the rhetoric of long-term decisions and all that, that is very much where politicians are going. And of course, the mission-led policy proposals from Labour are very much in the same theme. Breakfast clubs, scans and vaccines, and leaning in on junk food. They've done a huge amount of polling. They would have found exactly what I found whenever I gain insight from the public. People are genuinely concerned about the futures for their children overall, for their education, from crime, for the economy, and for health. And health has definitely moved up the agenda. And so what we're looking at, I think, is a changed political environment where people personally and within their communities are angry that they've been let down by a system. They love the principles of the NHS, but they want support. They want to be able to have the agency to affect their own health in their workplace, where they live, and in their own homes. And that is where the politics is going to be. The economics is already very much focused on workforce health in a way that it wasn't before. And the idea that more of the same is going to fix the NHS is well and truly over. And the mood is, I think, very much around trying to think about a shift to the left.
Thank you, James. It was brilliant. Thank you.
Yeah. So I think those two talks have set out in the most convincing way why a shift to focus on prevention is absolutely the obvious thing that any incoming government after the next election should be doing. I mean, it's really difficult to find anyone who thinks about this for more than a few minutes who doesn't conclude that this is the right thing to do. And actually, if we've looked back over 20, 30 years and we look internationally, most people, when they think about health for a little while, conclude this and have concluded this for quite some time. And it's one of those areas where actually it's really hard to find disagreement on the objectives. But Sam Friedman points out the policy paradox that we're faced with so often, which is that the more obvious a policy solution is, the less likely it is to get done. And to some extent with prevention, you could argue that, this has been the thing that we've known for a very long time that we need to do. Sometimes we talk about it as the left shift. It's been in so many documents for so long, and yet we've really struggled to make a reality of it. So I thought that what I would do is think about this from a policy wonk perspective, which is what I'm naturally at home in, and think about then in terms of an incoming government and through the next year, what would we want them to sign up to do then? Actually, to go from our very high level commitment to this, an intellectual buy-in to this, to actually being able to achieve the shift when you hit the realities of governing a country. And we've been thinking about a number of things. And I think the thing I want to emphasize is I think in that there is no substitute for the deepest of political commitment to it. When you look across the board at where we make structural shifts, one, they take time. And the OECD did some very interesting work looking at pension reforms of some of the big utilities, reforms of labour markets that have gone on over recent decades. They take time and they take deep political commitment. And actually what you want is some kind of cross-party consensus in that, so that because they do take time, you need some continuity of purpose. And our system obviously makes it quite difficult to do that because we accentuate the difference rather than the alignment. But within that, although obviously political commitment matters enormously, I think there are things we can do in using some of the institutional levers in our system that make it a bit easier for politicians to follow through on that commitment. It's not a substitute for the commitment, but it can help. And we've been looking, I think, at sort of 3 or 4 things that seem quite important in this area and learning from other areas. And one of those really is about how do you create some positive political capital from committing to do this? Because one of the challenges with prevention is that if you do, especially in a system where you're going to be very resource constrained and services are under a lot of pressure, is you're going to sacrifice some gains today in very obvious things, in immediate need, which are really important to people, for doing the right thing that in the end will unlock wider benefit. Now sometimes the timescale could be comparatively short. Some of the smoking things, it's not all 10, 20 years, but inevitably it is a delayed benefit. Yeah. And so that's quite hard. So finding a way in which you can create some political capital, some political mileage in making that commitment now and being prepared to prioritise seems very important. And we think there is some learning to be had from climate change and from net zero, and thinking about trying to a number of organisations are calling from variations of a Bill of Health, setting out a goal or a target for improvement here, with some accountability mechanisms there, where a government can very clearly signal its commitment. And I think the work that we've been doing, colleagues at Demos and I, thinking about the fiscal rules, is also trying to create some of this political win. So trying to create a visible category of spending for prevention, so that if you shift resources into prevention, which we know we need to do, and shift the balance there, rather than it being a hidden thing where you've just done the right thing but no one gives you any credit for it, you can actually create some credit for it. So you can very clearly show that you had this intent and you're following through on that and what you're going to do, and that and delivering on that becomes something which you can actually start to shout about, rather than quietly happening but people see the pain of what you're not doing, perhaps in immediate need. So I think that trying to create some positive political win around that. The other thing it does, hopefully, is create a commitment device, which makes it harder when you're in the reality of government and the argy-bargy of things like spending reviews. And I am a former Treasury official, where you can start to have the conversation that says, okay, so obviously we could raid the prevention budget, but do you remember we have all signed up to that very publicly? So actually that's no longer a pain-free option for us, to get us out of this difficulty. And across government, then you are signed up to that, and that one of that thing that does is hopefully slightly recenter some of the terms of trade, and you can all try and bind each other to that as well. And of course, finally, what it does is create the transparency and the public accountability about that. So if you do what you know to be the wrong thing, which is to cut the prevention budget and renege on the commitments, to push them all out another 5 years or whatever, very quietly and under the table, because you've got this immediate, really difficult problem at the moment, it will be much more obvious that that's what you've done. And there is then hopefully a bit of pain to doing that. So we're trying to think about, and this is sort of borrowing, I guess, from some of the insights of some of the more behavioural economics, how do you use some of those devices in government? They're not slam dunk. Even in climate change, we've seen whether legislative requirements are quite strong. But what they do is shift some of the centre of gravity, create a win and increase a bit of pain, and bind people together a little bit more into achieving that. And I think what's really important there is that we think about how that follows through all of the different levers that government has got. So we're thinking about legislative frameworks, about accountability mechanisms. We've got climate change committee. Should we have something similar about fiscal rules, about ring fencing budgets, about setting forward spending trajectories for those that you ring fence, about hardwiring some of this into some of the ways in very nerdy areas like the way money flows within the NHS in payment systems. And all of that, I think, is really, really important to try to make this something that is part of the way that government governs, and is fused through its ways of working. But the other thing that strikes me that's really important here, and is different in this moment, is we're also at the moment, I think, in the middle of a paradigm shift where we're not going to have lots of extra public spending. And
Yep.
you know, whoever's in, and for certainly, you know, I'm 10 years off the retirement age. So if I work that 10 years, I'm not envisaging ever going back to my early days in the Treasury, where my job was to spend large amounts of money and think creatively about how to spend large amounts of money. I can't see that ever happening again. So we are about radical transformation within the state, and all these measures are really important. But we also need to think, I think, very differently about the balance of responsibility here between the state and other parts of society and the economy. And I'm very struck here by Danny Roddick's work on productivism and what she calls a new quid pro quo between, if you like, government and the private sector and wider society. And in that, and I think some of the examples that James talked about are quite nice examples of this, and the Wakefield one is a good one. But also, actually, I think the sugar drink levy is a great example of this in action, which is that government needs to be profoundly pro-growth, yeah, because that's going to be fundamentally important to our ability to give children the best parents have to do all of this. But the private sector needs to take responsibility for its social externalities as well. And we need to have a new settlement and an agreement that enables that to happen. So, you know, if we can't get our population to be healthier, we will not be productive. That is very clear. And we will be locked in a new cycle. But also, actually, this is a two-way street, yeah? And so the private sector has a key role also in helping us to be healthier, to be that sort of society which tackles social problems and has those outcomes. So I think there's a big agenda here for government, which I've set out. We need to change a lot of the way that government works to be much more pro-prevention through all its tools. But actually, it's a moment where we also need to have a conversation beyond government to think about a change in the social contract and the role of all of the social partners in prevention.
Brilliant, thank you.
Very
That's
good.
very inspiring. Those were three great introductory remarks. Thank you. I'm just going to ask a couple of questions, and then we'll go down around the room for some more. I don't kind of indicate if you want to go first on this one. I don't have an order in mind. Do you think it is politically possible to shift to additional spending on prevention without at the same time delivering additional spending for the more acute services? And I just I'm going to be completely honest, that the conversation then actually left me less optimistic than I was before, because I was thinking about this, and as the fires in acute services potentially get worse, the skeptic and the pessimist in me feels like this is only the sort of thing you can do. It's like the fix the roof when the sun's shining thing. Like, was this what we had to do in the noughties when waiting lists had come down, and in the sort of more acute services there weren't literally fires everywhere, we didn't have crumbling schools. With that environment, you could have said, right, we've put out the acute day-to-day stuff is, obviously people will question it, but it's sort of working. Now we can spend the proceeds of economic growth, which we had. It's just leaving me feeling very depressed.
No, but you shouldn't feel depressed.
Go on, James. Tell me why we can politically do it, because it still feels. I agree, the public have moved on nanny state, and the politicians recognise that.
No, but where you're right is it has worked for quite a long time, like 40 or 50 years, that focusing on acute care improved our health quite a lot. And actually in 97, if you know, in those days, actually winning the argument that reducing waiting lists was something that had to be won at the time. So clinicians didn't necessarily buy that as an argument. You have to go back and talk to the people at the time and say, no, we had to make the case that reducing waiting lists was a thing.
We were clogging up waiting rooms.
Right.
Yeah, we were clogging up waiting rooms.
And doctors are like, well, I don't think about it. So these arguments can be won. Where you are right, that the idea that we're going to wrestle money off acute care, off the consultants and CEOs of trust, that ain't ever going to happen. They are so tough. They need a lot of money. They are the big sort of super tankers, the aircraft carriers. They are the fleet captains who will not negotiate on resources. End of story. So that the idea that you can send in a sort of Simon Stevens type person to kind of like chip away at their budget and give it to someone else for prevention, that ain't going to happen. Where things can happen is, firstly, the politics, as I was saying, has changed, and Anita alluded to it. There are quite a lot of things we can do that aren't to do with healthcare spending. We can do things. I mean, if we ban smoking tomorrow, that would massively improve the health of the country by Christmas. So there's some early moldy homes, trickier. That's a huge estate of homes.
Very high cost.
But well, even if you targeted the homes, in Denmark there are pilots where they find the kids who have respiratory disease and then do their homes. And actually, if you're thoughtful about it, you can. So there are some things that don't cost any money or don't cost a bit of money and got nothing to do with healthcare. And then the politics is changing because people are demanding that their own communities are healthier. They're fed up with, Sadiq Khan's got rid of junk food advertising on the tube. It's popular. He's doing ULEZ. It is basically very popular. So that politics is changing. And then lastly, the social contract on health is changing. And I think both alluded to this. We are going to look to other people to contribute to health. I'm not saying paying for their, £10 if you don't turn up to the GP and sort of, old Tory sort of red meat type ideas. What I'm saying is we have to get away from the idea that the point of the NHS is that you lead your life however you like, and then you stumble into A&E, pissing blood and poorly and ill, and then the NHS is going to mend you and make you better. That model is flawed for several reasons. One is, if you are ill, I'm afraid to say, if you have a heart attack when you're my age, you will more or less knock 5, 10, 15 years off your life expectancy because of the damage done by your heart attack, your diabetes, your respiratory disease. That is just a fact of life. Now, it was 30 or 40 years ago, if the NHS put you back, actually you had done quite a lot for someone. Nowadays, people are carrying multi-morbidities and the NHS has nothing to do for you. You kind of have to mainly do it for yourself. And there are things that all of us can do, and there's things that employers can do, and there are things that local councils can do to create healthier environments, to be on top of your own personal health, to take the screening and vaccine advice. So that bit of the social contract, I think, is going to change, and people are going to be contributing to the healthiness of the country, either by looking after themselves better, by looking after the workforce and employees better, by thinking about the environment in which people are living. Those upstream interventions are a massive investment in the country's health, and I think will make a big difference.
Thank you, James.
Just one other thing. I think this is where it's really important to have at least a whole parliament and probably a 10-year horizon. Actually, if you look at where the NHS is at the moment, the idea that actually even if the Treasury said blank check and threw every pound, they have, at it, that very rapidly you could turn things around and waiting to go is not realistic. And I think people know that. I actually think the public know that, and they recognise.
Can you explain why it's not realistic?
We can't magic up physically that much capacity, overnight to treat 7.7 million people, and then if you did the bottlenecks in social care and all that, because this is a multi-system problem that's going on that's led to this, and I think people know that, and I think there is an appetite for credible, serious, long-term solutions, a sense in which there are some fundamentals that are wrong. This is not just a sort of short-term quick fix issue. We have the right model and we just fiddle around at the edges, throw a bit of money at it, which in previous times you could have argued, and so But I think the trick here is therefore to set out that longer term plan, 5 years, 10 years, which does involve then a structural shift towards more prevention. And again, I mean, everything I've learned from working in public sector and public services is you have to take your time to build things up. I remember I was at the Treasury when Sure Start was thought of. And a leading politician at the time, about 9 months after it had been in the spending review, said, "Can I go and visit one?" I said, "Well, they're not there." No, they're not there. Why aren't they there? Well, because, as you're going to do this well, it takes time. And so if we're going to do prevention well, and actually not snatch defeat from the jaws of victory, we want to do it really purposefully and carefully so that the things we invest in make a real difference and build support and build credibility and over time. But the art of doing this, I guess, then, and the really smart politics, is you take that long-term perspective, but you create tangible, positive wins and change that people can touch and feel in their real lives as you go along, don't you? And that's really important. And I guess you want to look to some of those things being things that don't cost you a huge amount of money and an enormous amount of infrastructure as you go along. And that's where really, and I'm not a really skillful politician, but that's where really skillful politics will need to play a part.
Yeah, I mean, I just really support the need for that more. The ability of the system to plan more long term. I mean, we're in breast cancer in the last 5 years, we've seen more new treatments coming that are life extending and life saving than in the past 10 years. So it's great that we're having all these really transformational treatments coming on, but they're, and they are expensive. But the thing that is causing the problems is just the fact that nobody at a service level can plan, because they don't know what their budgets are, they don't know how many patients they need to be treating, because they don't have the data to count the number of people with the secondary breast cancer. And so we're just working with a system that is just can't take a second to think about how to plan the next few months, let alone the next few years. And how can anyone run any kind of organisation? I mean, the charity that I run, we're thinking about how we plan our financial sustainability for the next 10 years. That's normally what we do in order to think about running a good, strong organisation. Now, we're expecting the NHS to really, to run on chaos. And I think to have longer term financial planning as the norm will naturally create a much better NHS system for us. And I do also think that these ICBs, I don't know what anyone else thinks about them, but I think having these integrated care systems where you do have community and local authorities as part of the, at the table, I do think that's really important. And that will help, preserve things like, local, low traffic areas and community sports and, links with schools. So I feel more of an optimist that there is so much that can be done just by giving the system the tools and the time to get on with doing a better job, and coordinating themselves and planning themselves and making the most of new innovations, new technologies, and allowing them to do what they're really good at.
I guess the one thing I would say, if I was starting to think about how to give this a shift to prevention a fair chance, and I had a little bit of money, where would I put it? And I wouldn't put it in the hospitals, I'd put it in local government, because the thing that worries me most, I think actually about the ability to deliver on this, is the fact that we've got large amounts of local government at serious risk of falling over in a really catastrophic way. And actually local government is an absolutely critical partner. And so that's where I think I'd want to most focus my attention, but that's quite difficult politically.
Good.
Cool. We've got time for some questions. I think Dan is appearing. Oh, wow, look at this. Welcome, Dan. Are you taking one of these? Yeah. Cool. So we'll do it in threes. So one at the front. Anyone else? We'll take one here and then the one over there. as well. Dan, did you see that?
Who was the first? So?
Just there.
Yeah.
Can you just introduce yourself?
Sure. My name's Sophie Ditch. I don't know if I need this.
No,
Sophie.
no, it's just for the live stream.
Sophie de
It is,
Schwarzberg Gunther. On a personal note, I've lost 28 kilograms in 3 years, and I'm no longer pre-diabetic. So I would like to say that self-care, in addition to healthcare, and Lord Bethel has totally championed this, is incredibly important. We also need to look at the food industry, not so much of taxing sugar, but educating people that there are 60 different names for sugar in all these foods that's put in front of us. I went into Pret a Manger the other day and tried to buy raw nuts and raisins. The only one available comes with chocolate in it. It's not possible to buy nuts and raisins from Pret a Manger without chocolate. So I'm just giving that as an example. So my points are sugar addiction, it's everywhere and it's very difficult. So we need education, we need self-care, and we can do it short term. If I can lose 28 kilograms in 3 years, I'm 55, post-menopause, and proud of it, it's possible. So I'm just saying we all need to take responsibility, but it's really hard with what the food industry is doing to us all day long. That's my point. Thank you.
Sophie. Gentleman at the front.
Okay, I'm Martin Ewell at the University of Manchester. In the book that we produced just a few years ago called Saving Sick Britain, which looks at prevention in toto, one of the points that we made in it was the need for a clear political slogan, if you like, that would, around which the whole argument about prevention could be articulated. And that point was to look actually at what is happening in South Korea. South Korea has set itself a national target of achieving a 75-year health span for individuals, not lifespan, but health span. Lord Bethel showed a slide showing the gap between health span and lifespan, and it was 50 years old for the lowest decile, going down to about 12 years for the top decile. Reducing that, extending healthy life by, say, 25 years for people who can expect it only for 50 years would be a major, major gain. Now, whether we could be as ambitious as the South Koreans, I'm not sure. Maybe we should be, but then it follows then a question of costs and so on. So maybe we need to be to set ourselves a target which is less ambitious, but nonetheless is on that road, and we can then improve the target thereafter. But with a clear target like that, it's something that everybody can get hold of, and which would allow us to begin the huge task of transforming the whole of government to be focused on prevention.
Thank you, Martin. And then the question over there, Dan, if you're right.
Who was it, sorry?
Yeah, over there.
Yeah.
Wave. Thank
Hello.
you.
Hi, my name's Sarah Gillinson. I run an organisation called Innovation Unit, and we help to grow and spread community-led solutions to big social challenges. So you won't be surprised at my question, which is about you all think about the role of devolution in prevention, because in our work, one of the things we find over and over again is that communities themselves are pretty darn good at knowing what it will take to help people be healthier and therefore avoid the comorbidities that you're describing. We work in Greater Manchester a lot, where the Mayor's commitment to live well means that organisations like GM Moving are helping people to get physically active, but they're giving it to local places so that they can say what's going to help people to get physically active. So in my world, the idea of devolving that little bit of extra money, not just to local government, but one step further to communities themselves, seems to me to be a key ingredient in all of this. What do you think?
Thank you, Sarah. So, a great question and kind of point from Sophie around self-care and the extraordinary change that individuals can make. We had some great comments from Martin around learning from South Korea and setting clear targets and the need for a clear political slogan, perhaps, for prevention. And then a great question there from Sarah, thank you, around devolution and prevention. Della, do you want to start us off? Yeah.
I'm wondering whether really what this is all leading up to is the need for climate change bill. I mean, I worked on the climate change bill when I was in government, what feels like a very, very long time ago now, and helped create the framework around that. I'm no expert on it, how it's all worked out, but I'm really interested in the idea of how you can create that transparency, but also something that reaches right into communities. And communities are not always about place, but because in breast cancer now, we work with communities of people who have breast cancer, so they come together online, they come together in support groups in different ways, and when women living with breast cancer are very interested in how they can reduce the risks of breast cancer coming back, and so the kind of support that they can have, whether it's through information, through through supporting each other and so on, it really is inspiring when you see people coming together there. So I love the idea, and I have seen it. So, and I also really love the idea of having a uniting slogan, a transparency, a theme, something that brings us together, that will give that help to build that political capital that Anita was just talking about, so that people. Wes Streeting can be brave when he comes in, if he comes in, about making those tough decisions and supporting the longer term investment in communities and in prevention.
Des, would you mind if, for the purposes of this rhetorical exercise, I strongly disagreed with you? Not through any,
not at all, no.
any even wafer thin gap between our motives, but I actually don't agree with the idea of the bill thing.
So the disagreement, that's what we wanted, James.
Just for fun.
Yeah.
So the three questions actually are that's the layer cake of state, community, and personal agency. And it is true that I agree with you that central government, maybe a bill, has a role to play, and there are some things in health that only there's a government can do at the top, like banning smoking or putting up excise. There are some population-wide measures, and there is some inspiration that the PM can do. When Boris did that amazing speech about the obesity strategy, when he said, I was 5 stone overweight when I went into a hospital with COVID and I nearly died, and I'm now going to try and lose my weight. That was incredibly powerful. I mean, the shame of it was that 2 months later he changed his mind and he put the weight back on and binned the obesity strategy.
Not that. If he had a bill, if it was held to account by Parliament with a weighing scale.
Well, actually, so there was a bill. So we passed the law and they revoked it. Yeah. So in that, I'm afraid, in that instance, he changed his mind. Philip Davis and Esther McVeigh went to go and see him, said that they would quit as Tory MPs, and then the
political capital
And
wasn't
what
big
happened with the
enough.
national food strategy?
Yeah. So what I'm saying, what I'm trying to get at is, yes, in health. So the determinants of health are, as I said, a bit clinical, a bit genetic, but mostly behavioural and environmental. So whereas with energy, the government is a massive procurer of energy. It is a massive investor in wind farms and things like that. Actually, you can change the energy requirements of a nation from the top down quite a lot. And bluntly, our own personal decision making about energy is a sort of marginal rounding error on the actual determinants of Britain's energy consumption. So the fact that I recycle my bins and traded my Land Rover in for a Fiat Cinquecento doesn't really make a big difference. What really matters is the energy policy of the government. Health is the other way around. What really matters are the decisions of individuals, and those are often determined by the environments in which individuals live. So I think national inspiration is important. Without it, nothing's going to happen, but it won't change it on its own. Communities, for sure. I mean, they know what works in Blackpool is not the same as what works in Berkshire and so on and so forth. And there, as I'm trying to hint at, I sense that communities are keen to lean in on health, and by the way, on climate change and on crime and on education. And devolution of health is definitely a key part of all of this. And anyone who's interested in devolution, I mean, I'm a massive convert. I'm a Tory, so like devolution, I have a slightly uneasy relationship with. But on health, for sure, I've become a big convert. And Sophie is absolutely right. The personal social contract on health has got to change. And that is true in Britain and in America and every developing world. We all face the same kind of Domino's pizza problem, that the excesses of modern world are having a terrible effect on our own health. There are some countries like Japan and Korea and Taiwan that have managed to figure this out a bit better than us. But I think we're all on a very, very similar journey. And it's not about banning people from doing stuff. I mean, I think there's some stuff that could be banned, but it's a lot about enabling people, giving them the data, allowing them to make their own decisions and not flooding them with the bad stuff.
Why don't we do another round of questions?
Yeah, sure. Get your hands up. Oh, there he is. Gentleman there. One. They all went up together, so I'm just randomly picking. Sorry. And then I think your hand was second, and then I'm going to go for right at the back. There you go, 3. Yes. So did you get that down?
Yeah.
Andrew, over to you.
Yeah, good evening, everyone. Andrew Bell from Reading Partnership. We're delighted to be sponsoring this evening, and thank you to the panel for a really fascinating discussion. Really enjoyed it. Just thinking about the contours of the debate in terms of intervention, does the panel think that too much conversation is dictated to what government should be doing and the role of the state and the role of targets and taxes, etc., to the detriment of wider society that Anita was touching on? For instance, what is the role of business in championing this agenda, and what more can business do to help government and help wider society to tackle some of these really important problems?
Thank you, Andrew.
Hi, Maddie Webb, or also Breast Cancer Now. I just wanted to ask some of the kind of public health interventions that have been named here and obviously have been championed here in terms of ULEZ and vaccination and the smoking ban. There's a risk in terms of the political conversation that they fall into either blame or the culture wars. So I just wanted to hear the panel's thoughts about how to have those conversations in the political space to build that broad consensus that isn't ideological without falling into those traps.
Great question. The gentleman right at the back.
Hi, my name is Hamad Khan. I'm a graduate medical student and also Global Development Officer for the Global Social Prescribing Alliance. I see the lens of prevention also as how we've instituted social prescribing in the NHS. And actually, England is one of the global leaders of social prescribing. We constantly have international delegations and showing how we can incorporate prevention and social care together and empower communities. I think that one of the issues or one of the things that we have to meet with changing the paradigm of the social contract, this new social contract of our health, is both patient expectation and physician practice. So we have this industrialized sick care service. How are we going to make sure that the future healthcare workers aren't perpetuating this sick care? Equally, how are we going to make sure that patients are actually empowered to have self-care when they don't have the social structural realities to improve their environments? Thank you.
Thank you very much. So social prescribing, how do we avoid culture wars on ULEZ, vaccination, smoking ban? A great question from Andrew around what's the role of business in all this. Anita.
Yeah, can I talk about the role of business? Because I think this is really, really important. And we talked quite a bit about the role of business in relation to the commercial determinants of health. And that's really significant. But I think we need to think beyond that. And I've been thinking quite a bit about the issue about rising numbers of people not in the labour market due to ill health. And this seems to be one where actually we need to approach that problem with the responsibility, but also the opportunity that business could play to be part of the solution to that, absolutely front and centre in all of the thinking about that. And the work that James showed that we'd done on projections of ill health, we've just had a look at that in terms of inequality and the working age population. And we've already got this huge problem. We're looking at potentially on current trends, 700,000 more people having major illness, and those people being concentrated in areas of disadvantage. And when we get into the detail of that, what we see, because it's really important to think about who people are in their lives and what's leading to that, are combinations typically of chronic pain, anxiety and depression, and quite often type 2 diabetes. That's the common kind of cluster. And then people can have that and stay in work if they're highly educated. I mean, not fully, but actually when you add in not having a level 2 qualification, you're much more at risk of that. So you think about this. I'm working in social care. I'm a woman in my 50s. I'm on 12-hour shifts, lifting. I'm on my feet all day. I've developed back pain. I'm really worried about, I'm in what is comparatively low wage employment. I'm really worried about how to make my rent, how I'm going to support this. I'm in pain. I develop anxiety and depression. I'm not self-caring as much. I've got diabetes. How do I need to transition to a different type of work? Yeah. But where's the help for that? Where do I get that? Is that all the state? Or actually, as employers who need a workforce? Yeah. So this is enlightened self-interest. What's the role of employers in helping to keep people in work and helping people to make the transition at points in time when they need to transition into, to manage their health into work, which actually, you know, is sustainable and helps get into be part of the solution, not just, you know, the economic benefit, but actually gets them into a cycle of improvement. And how do we work? And you see enlightened employers who are doing this, taking that responsibility. One of the great things through the pandemic is employers saying, actually, in particular, the mental health of our workforce is something we're really worried about and we need to lean into and step up to. But how do we do that more systematically and really make sure that employers are playing a full role in the solutions to that? I think that's a really important question. And I think if we just say, okay, we wait for people to fall out of the labour market, I mean, getting people back in is a nightmare. And we say the state will pick up. And actually the sort of sophisticated whole person policy making that you then need in service delivery looks very complicated in our state structures. So I'm not very optimistic that even if we did a state entirely focused measure, that it would be very effective either.
Can I make a quick plug to build on the social prescribing point? I mean, from the community voluntary charity sector, there is a huge wealth of interest, experience, commitment, drive to want to get behind all of this. And there's a group of charities that we're part of, the Richmond group of charities, British Heart Foundation, Diabetes UK, Stroke Association, all the common conditions, thinking about how we support people with multiple long-term conditions. Social prescribing is a really great idea. When I think about the challenges that health professionals have when they're dealing with people who are really going through tough times. So sitting down with a woman who's just been, that just finished her breast cancer treatment, she's got to look at 5 years on tamoxifen, chemical menopause, and the chances of reoccurrence are very much on her mind. One of the biggest things that she can do to help reduce her risk of reoccurrence is exercise, and no one talks to them about it. No one talks about exercise. I sat with my sister when she was going through her being prescribed her chemotherapy, which is, anyone who's had chemotherapy knows how hard that is. The percentage gain on survival was estimated to be 4%. That is the same as exercise in that particular situation. So there is an enormous shift that could take place, and I think the gentleman at the back is nodding, and I think it is something that could really reap huge benefits if further developed and promoted and encouraged.
James, the final remarks have fallen to you. You've got about 30 seconds.
Thank you. So I think that the politics of this have changed. I mean, I said it have changed a lot. I think that the newspapers have changed their attitude. The Telegraph is hard over on prevention. They're running supplements almost every week now. Daily Mail, very supportive of smartphones and the smoking ban. The Times is like ultra radical. It's like a sort of militant group on prevention. MPs on a constituency basis are all arguing for more green spaces, more physical activity, more diagnostic hubs, more community health involvement. It really is a sort of nexus of just quite a small number of people in the centre of the health Westminster kind of political bubble who are quite entrenched, old-fashioned views that fear nanny statism and sort of have conversations about freedom and liberty that are quite sort of out of touch with where most households are in their own views on health. Now, unlocking that is not straightforward, but I think we're at a tipping point. You know, people often say, you know, like with gay marriage, you know, a lot of people seem to be against gay marriage for a bit, and then suddenly everyone was like, of course we should have gay marriage. And I think we're at a tipping point like that with prevention. Everyone is now like, oh, we need more doctors and more good old nurses. And now I think everyone's like, you know what, we need to sort this out. We all need to collectively lead slightly healthy lives. And could you please throw away the Domino's leaflets?
Seems like a great note to end on. Thank you so much for great questions.
Thank you, Ben.
There's